Welcome to the Vet Dental Show. I'm Brett Beckman. I'm a board-certified veterinary dentist, and we come to you every week on Wednesday to provide the veterinarian and the technician team some actionable things that you can use in your practice. And this episode is going to be a recorded episode that we've done in the past, not a podcast that we've recorded or not the Vet Dental Show, but actually some other information for you that we know you're going to enjoy. So sit back, enjoy, and we'll see you at the end of the podcast. And Amanda asked the pain management strategy for mandibulectomy patients. And generally, with mandibulectomy, there are, unless they have tooth-on-tooth trauma or tooth-on-tissue trauma from the mass, moving things or being space occupying, they're usually not uncomfortable. So we generally don't do a pain drip unless it is something like osteosarcoma that involves a bone, or there is definite pain response when we do our exam, or notes from home that yes, they're uncomfortable, they're showing signs of discomfort. So for mandibulectomy, it's not much different than for a multiple extraction in multiple quadrants. We're taking bone and we're taking tissue, and then we're suturing all that back up. So we don't leave any inflammatory tissue. We get all of that out. So it's a nice, clean post-op site. And so we would use an NSAID, and plus or minus, if the patient was chronic previously and had pain, we'd have gabapentin on board already. But an NSAID and also a fentanyl patch in our hands. Certainly any combination thereof could work well as well. But nothing severe, just an NSAID and that opiate is the best way to go, and they do really, really well with that. So thanks, Amanda, for that question. Holly asked, would we recommend sending in every epulus for histopath, or what makes you decide when that's necessary? And in general practice, in specialty practice, it's best to biopsy anything that's abnormal. And we'll talk about specifics a little later with some other questions along this line, but we always recommend that you biopsy before you make that determination. Now, one exception to that is with patients with multiple lesions that is likely in the category of gingival hyperplasia, which we discussed in one of the cases previously. In that case, we wouldn't biopsy everything because basically we're going to treat that case kind of the same way, in that if there's a real proliferative mass that turns out to be an epulus, and we excise it in the whole process of doing the treatment for hyperplasia after we confirm with x-rays that there's no significant perio around where we're doing those excisions, then we do the excisions, we take appropriate biopsies, and by appropriate I mean, and again, we're talking about gingival hyperplasia cases as being one exception, that we don't biopsy everything. When that happens, there's going to be 3, 4, maybe a couple more areas that are more angry than others. And so if there's any question, that's how I would approach it. I would make sure that we look at that as the ultimate treatment outcome in the future. So if it's hyperplasia, the majority of it's hyperplasia, which it generally is, then what we're going to do is we're going to take and use that excision as the treatment for whatever we take off, biopsy or not, and then we're going to come back and we're going to check that back in 3 to 4 months and see how much regrowth we've had. And usually there's not much, but in the case of the epulids that show, if they're at the same rate as the hyperplasia, we don't have to necessarily remove teeth going forward. we can just get them back at whatever interval that is. Maybe it's 6 months, maybe it's a year, where they need that hyperplasia kind of touched up a little bit, and just touch up the epulids at the same time. And histopathologically, Dr. Cindy Bell, who most of my colleagues in the specialty board send their histopath to, as well as we do, there is not a lot of differentiation from a pathology standpoint from gingival hyperplasia. So if you can control it that way, great. If the epulids grow faster, then that's an indication to remove the epulids, along with the tooth, which is what we generally do. So I hope I haven't confused you. And that's a big answer to a short question, but basically that's how we would approach it. We would not biopsy anything that is, we would not biopsy everything in a hyperplasia case, but we would side on biopsying anything that's not suspected hyperplasia. That could all be epulids, or they could be other things. And malignancies can certainly mimic each other. So Reba, margins for melanoma and squamous cell carcinoma, those ideally are 2 to 3 centimeters, but 2 to 3 centimeters generally is not something that's going to be functional for the patient. It's going to be very invasive. So if we can, and we can maintain normal function and not get too aggressive, we recommend doing that. And if there's an instance where we suspect that squamous cell is in the mandibular canal, we need to do a whole total mandibulectomy and not just a partial. So that whole side up to and including the ramus would need to come out. So I hope that answers your question. John, are these with juvenile onset perio more prone to developing stomatitis when they get older? And juvenile onset perio, we have to watch that, because a lot of times we won't have caudal mucositis early in the condition. And if we just assume this is what it is, and we don't check that each time the patient comes in to look at that caudal oral mucosa and see if it's inflamed, that is consistent with stomatitis, then we may miss these and pick them up later down the road rather than earlier. That said, you don't want to jump on that immediately and see some inflammation in the caudal mucosa and say, well, there's a little bit back there, so this is stomatitis. You want to make sure, if you're catching it really early, you want to make sure that it does progress and get worse. So don't jump on them too early, but know that you need to be watching them, because there may be some, because of the inflammation there and the response to inflammation, there may be some carryover with that. There may be some relevance, but at this point, I don't think anybody knows. Reba, when we're talking about juvenile onset perio progresses rapidly, it starts at 6 months of age, and it depends on the patient. We can have patients that are 18 months that need full mouth extractions, or they can go years and just have bits and pieces of extractions done over time. So all of them require frequent cleaning in the hospital if we're going to maintain them, but it varies considerably with the patient. I hope you enjoyed this episode. There's a lot of actionable items in there that you can take and use in your practice immediately. So put those to work and enjoy the benefits for the practice lifetime in your dentistry service. And if you would, please go to iTunes, leave a rating and review, take a picture of that with your cell phone, and then post it on the Vet Dental Show Facebook page. Just go to Facebook, search Vet Dental Show in the search in the upper left, and the show will come up. And once you post that, we'll send you a free instrument use essentials course. So if you want that free course, again, all you have to do is go to iTunes, leave a rating and review, take a picture of the rating and review with your phone, and then post it on our Facebook page, The Vet Dental Show. So until next week, Have a great week. Take care, guys.